are glad to greet you on the webinar of the campaign 146 by 24, which is conducted by the TBEC and ITPC in the EECA region. We are going to discuss the efforts to increase the efforts to liquidate TB by introducing the shorter and more efficient treatment regimens for and prevention regimens for TB. Today, Madlen Nash, Master of Science and member of the Coalition 146 by 24, will present you a report which was prepared by Treatment Action Group. The report in Russian and in English languages is also published on the website of ITPC and on the website of Treatment Action Group. I'll share the link in the chat box so that you would be able to read this report in more detail. After Madlen makes her presentation, we will have time for questions and answers to the speakers and to discuss the suggestions or country barriers which prevent you from implementation of this campaign in your regions at a full scale. If you have questions during the presentation, please write them in the chat box. And now I'll give the floor to Alexandra Vasilenko, PR manager of TB Europe Coalition. So you're welcome. Dasha, thank you very much. Dear colleagues, hello. I'm glad to see you all today at this webinar. And on behalf of TPEC, I am greeting you within this webinar, ABC of TB activists. We are conducting such educational webinars and discussing very relevant topics related to TB. And thanks to our partners from TBEC and EECA and ITPC, and thanks to participation of Madlen Nash, our wonderful speaker, we will be able to learn the results of introduction of this campaign 146 by 24 in the EECA countries. Maybe you remember that last year in June, we already had conducted a webinar during which we informed about this campaign, about this very important initiative related to the changing in the treatment regimens. And I will be glad to hear about the results which we managed to achieve, who managed to achieve what, who had which barriers in the countries, so that we would be able to address these barriers. And I wish you all a fruitful webinar. Thank you, Alexander, for your introduction. And now I will give the floor to Denis Godlevsky, regional coordinator of the ITPC in Eastern Europe and Central Asia. I'm glad to see you all. So, and I understand that this topic is interesting for you, and we are glad that in collaboration with the TBEC, we are able to present the Russian and English versions of this report. And I'm using this opportunity to make an announcement about another initiative which will take place this year within our cooperation. In summer, it is expected in the end of July, we will have another series of recruitment of participants of Smart TB CAB, and these are educational modules designed for several weeks, during which you will be able to increase your knowledge about TB, about clinical studies, about clinical and treatment protocols, about the activities of communities, about advocacy, and so on. So please follow our announcement and announcements of our partners and submit your applications to participate in this educational series. I see that some of today's participants already took part in these training webinars, and so I'm giving the floor to Madlen. Thank you very much, Denise. And before giving the floor to our speaker, I would like to remind you how to change the language of the presentation. In the top right corner, you can select an icon and select the view in Russian, for which you should select Alexandra Vasilenko, and to view presentation in English, you should select the screen of Alessia. And now let's start this presentation, which is most interesting, and I'm giving the floor to our speaker. Madlen, you are welcome.
Thank you so much, Daria. Can everyone hear me?
Да, спасибо большое.
I think I maybe need to mute the translation. Is this working? Okay, excellent. Thank you, Daria. Thank you, Dennis, to all our colleagues at ECAT for having us on this webinar and for organizing it so brilliantly. And thanks to you all for taking the time to be here. So I'm really excited to share with you about the 146 by 24 campaign and about the report that we recently released around the midpoint of the campaign in both English and Russian. So you can advance to the next slide. So as you all know, thanks to, now about 2 decades of renewed investment in TB research and development, there are really exciting new innovations in the landscape of TB that allow TB to be treated in much shorter and safer and friendlier ways to patients. Yet the reality is that very few people have access to these new treatments compared to the number who need them. And this lack of access is really, an affront to fundamental human rights that, does inspire outrage among the global TB community. And this is really the foundation upon which the 146 by 24 campaign was founded. And don't worry, I'm going to get into what the campaign and those numbers mean if they're not familiar to you. Next slide, please. So this will be very familiar to you all, but I think it's helpful to just really take stock of how far we've come in TB to look at the length of time and the types of drugs needed to both prevent and treat different forms of TB prior to this, innovation in recent years. So where it took, 6 months or more of drugs to prevent, TB infection from becoming TB disease, 6 months again of treatment to treat drug susceptible TB, and 18 months or more, 1.5 to 2 years to treat TB that is resistant to first-line drugs. And now with these recent innovations, the short course regimens, we can now prevent TB in as little as 1 month, or 3 months with drugs taken weekly, and we can treat drug susceptible TB in as little as 4 months. So treatment time cut by a third. And I think, really significantly cutting the treatment time for drug-resistant TB, again, by a third, and also removing some of the most toxic, dangerous drugs from the older regimens. So really a very significant amount of progress over the last couple of decades. Next slide, please. So what does 146 by 24 mean? So as I described on the last slide, we can now prevent TB in as little as 1 month, or by a once weekly dose of a medication over 3 months. So that represents the 1. So these are regimens that are probably familiar to you, 1 HP and 3 HP regimens with isoniazid and rifapentine, or 3HR, a 3-month regimen with isoniazid and rifampicin. So the 4, here we're talking about treatment of drug-susceptible TB. There are 2 different regimens that sort of fall under this category of 4. This is 4-HPMZ, which is a regimen to treat drug-susceptible TB in adults and adolescents, and 4-HRZE, which is a new regimen to treat children who have non-severe TB disease. The 6 refers to the 6-month regimen to treat drug-resistant TB. So this is 6 months of BPALM or BPALM or BPAL, depending on resistance to fluoroquinolones. And the 2024 stands for, the idea was to achieve universal access to these new improved shortened regimens by the end of 2024, which is now the end of this year, just about 6 months from now. And also integral to the campaign is this idea that we need a fundamental sort of health infrastructure system to support the scale up of these regimens. And in the campaign, we're referring to that as the staff, space, systems, and supports, which Dr. Paul Farmer of Partners in Health talked about as sort of the critical foundation upon which, the human right to health could be achieved. And additionally, the campaign really emphasized priority research into gaps related to the administration of these shorter, better regimens in historically neglected populations from research, like children, like pregnant and breastfeeding people. Next slide, please. Sorry, I think I'm getting a language alert. Daria, is it still coming in clear? Yeah, okay, good. So where are we now? So as I mentioned, the goal, end goal for the campaign is 2024. So if we sort of take a look back, this campaign was launched in mid-2022 by civil society actors, including Treatment Action Group, Partners in Health, Médecins Sans Frontières, at the AIDS conference in 2022. And since then, a number of things have happened. Really critically has been the role of civil society organizations that have supported countries and civil society actors in countries to advocate for the inclusion of these 146 regimens in their proposals to the Global Fund, in their national strategic plans, and also to advocate for the importance of uptake of these new regimens at the UN high-level meeting late last fall. So when we launched the report, which we did in English just a couple of months ago, it was around just after the midpoint of the campaign, where we had only 9 months left to really achieve these very ambitious goals. And importantly, we're also only a few years out from realizing the commitments that were made at the UN high-level meeting. So where are we now? We're in kind of a crunch phase for really rapidly scaling up access to these regimens for everyone, and especially in the places that need them most. Next slide, please. So this is the image on the front of the campaign, mid-campaign report, which we entitled Getting Better Faster. And now, since we're a few months past the launch of the English version, we're even that much closer to the end of the campaign, which is the end of this year, just a few short months away. So there's really a sense of urgency among all people involved in the campaign about really doubling down on our efforts. So that's partly why I'm very excited to ECAT helped us organize this webinar, so we can really bring in stakeholders and partners from all of the different regions that are going to benefit most from having the goals of this campaign realized. Next slide, please. So in terms of the approach that we took for the report, we drew on a number of different data sources, the World Health Organization report, some data from MSF, from USAID, but primarily the analysis that we undertook was looking at the funding requests that countries did submit to the Global Fund, and seeing, based on that, what countries' plans were and are to scale up these shorter regimens. So a lot of the data that I'm going to talk about over the next 15 minutes or so is really drawn from this analysis. And the detailed table, which I know is not easy to read on this slide, can be found in the report. Next slide, please. So jumping right in, I think there's really a lot of reasons to be optimistic about scale up of these one regimens. So this is the shortened regimens for TB prevention. Most countries indicated plans to scale up 3-HP in particular, which I think is very encouraging. And as you all may know, the recent announcement last year of the child-friendly formulation for rifapentine is going to make offering these shortened prevention regimens to children that much easier. And that really speaks to, I think, what the priority needs to be around the one regimen, which is improving coverage, among children and among other people that haven't historically been prioritized for TB preventive therapy. So those over 5 years of age and not living with HIV. Interestingly, as well, 1HP doesn't seem to have, as widespread access, probably partly due to its higher cost. So also scaling up access to that regimen so people have options and can really choose what works best for them will also be important. Next slide, please. So compared to the one, there is decidedly, less progress to report on the 4-month regimens. So this slide is specifically looking at 4-HPMZ. So this is the shortened regimen for drug-susceptible TB for adults and adolescents. And we really wanted to dive into this regimen as part of our report and analysis because the gaps are so large. So one thing that we did was commissioned a modeling analysis to look at the potential impact of scaling up this 4-month regimen. And the results of this regimen show that switching all eligible adults from the 6-month regimen to the 4-month regimen through the year 2030 would result in 76 million months. So that's 6.3 million years saved on TB treatment. And so what this sort of image shows is just all of the benefits that would be afforded to patients by having that amount of time of their life back and not having to be on TB treatment. So it's really significant impacts, things like getting to spend more time with your family and your friends, having a reduced burden for your caregivers, having to spend less time and less money going to and from the hospital. So I think it's really important as we, push for greater access to the 4 regimens to really bring these benefits, to the forefront. In addition to time saved, we also looked at cost saved to patients. And again, the modeling analysis that we commissioned and included in our report shows that if all eligible people in just a sampling of countries in India and South Africa and the Philippines alone received this shortened regimen in 1 year, this year, 2024, the patients themselves would save a cumulative $110 million in non-medical expenses due to the shortened duration of treatment. So this is things like from lost wages and transportation costs. And these savings would go a long way to realizing, the UN targets, for instance, of avoiding catastrophic costs and really just taking, this incredible financial burden off of patients. And, we also expect there to be health system savings as well as demand and volumes increase for these regimens and prices come down. So that's really the focus, I think, going forward for the 4 regimen. Next slide, please. So further looking at the 4, so this is the 4 regimen for kids with non-severe disease. And this regimen is really a no-brainer, because if you look at it, the regimen uses the exact same drugs as the original treatment regimen, the 6 months of 6 HRZE. So, recent research showed that regimen can, with the same drugs, can be shortened by a third, so to 4 months, and still have the same efficacy for kids with non-severe disease. So it's going to be important for countries, I think, to realize the benefits, of that shortened duration. And we are seeing in our analysis, we are slowly seeing some interest in scaling up this regimen. And that's perhaps partly because 4-HRZE was included as a program essential by the Global Fund. And, the fixed dose combinations exist, the drugs already exist and are used, routinely in countries in programmatic settings. So I think now the focus is on, increasing awareness and demand for these regimens, and also helping countries, figure out the best ways to adjust their national policies and their clinical and diagnostic algorithms to support the identification of kids with non-severe disease specifically. And I think there's a great case study in the report of how Kenya has done this really successfully. Next slide, please. So turning to the 6th regimen for drug-resistant TB, so this is BPAL and BPAL-M. Out of all of the 146 regimens, I think we saw that country ambition and plans to scale up the 6 are really, among the highest out of the 146 regimens. We looked at a few things here. We looked at procurement of protominid over the last few years from the GDF and see major increases, between 2022 and 2023, which is, indicative of more countries using the BPAL regimen. And while that's encouraging, I think we also wanted to highlight that, while we're seeing big increases, still the absolute numbers of procured courses are really just represent a fraction of the people in need, the people who are being treated for drug-resistant TB globally. And of course, that just represents a fraction of the need, because we know, only less than half of people with drug-resistant TB actually receive a diagnosis and are therefore able to be treated. So while progress on the 6 is encouraging with the decreased regimen cost and the scale up that we're seeing in countries, I think it's important to look at it in the larger picture and realize there's still a long way to go to meet need. Next slide, please. So these are, as I said at the beginning of the presentation, a few of the foundational sort of cross-cutting elements of the campaign. One of those is a focus on historically neglected populations. So primarily, in this case, children and pregnant people. And we, if you look at the past, for TB, but also for other drugs, it's really abundantly clear that children and pregnant women and people are often the last to be able to realize their right to benefit from scientific progress. So the 146 campaign was really cognizant of that and wanted to try and make an impact on that really unjust reality. So the campaign called for very specific research to fill gaps, and it's really exciting to the report. And in the report, we have a table that highlights all of those gaps, and I really encourage you to go look at that in detail. But I think going forward, some of the priorities are going to be really scaling up these new regimens that have recently, been proven to be effective out of the NTB trial and the Beat TB South Africa trial, and making sure that pregnant women have access to those regimens, given that they aren't able yet to safely take some of the other shorter regimens. Next slide, please. Another cross-cutting aspect is really the access to diagnostics, which is a fundamental part of the campaign, realizing that people can't receive better treatments unless they receive a diagnosis. And our analysis of Global Fund concept notes shows that countries are scaling up rapid molecular tests and decentralized drug susceptibility tests. And this is very important, not only for the 6-month regimen to treat drug-resistant TB, but also for the shorter regimen to treat drug-susceptible TB, given that for HPMZ, because it brings a fluoroquinolone into the first line of TB treatment. Next slide, please. So we make a number of calls to action in the report for a variety of different stakeholders, including country governments. Really, the call there is for them to increase their investments, for high burden, low income countries to increase their domestic investment in TB programs, and for high income, low burden countries to increase their multilateral funding to support countries to scale up these shorter regimens. We make specific calls to the World Health Organization around for HPMZ, because the gaps are so great there, both to track and promote uptake of this regimen like they do for the other shorter regimens. We make calls to funding agencies to make investments in program quality, to support civil society for things like community-led monitoring, and to research funders as well to fund these needed studies for children and pregnant people. Some important calls are also made to market-shaping actors, again, with a focus around 4-HPMZ, looking at how we can most strategically shape the market for this better but still more expensive, shorter regimen. And then, of course, there are the calls to industry to reduce the price of key drugs, specifically around delaminid, which is a key component in the shortened regimens that are safe for pregnant people and children. Next slide, please. So I think a really exciting component of the report is these case studies that we've done on country leaders who are really been successful in implementing some of these shorter regimens, some, getting to at scale in their countries. And it's exciting that there are a number of countries in the Eastern European region that were highlighted. So I'm just going to quickly, Daria, am I doing okay for time? I have just a couple slides left. Okay, good. I'm just going to highlight some of the countries in the region. So next slide, please. So one of the case studies is on the scale up of 4-HPMZ. So this is the shortened regimen for drug susceptible TB for adults and adolescents in Azerbaijan. When we spoke to representatives from the NTP for this case study, they talked about the burden facing young, working men, family men in their country, and how really treatment adherence due to the length of treatment and the impacts it had on work was really significant for that population. And I think that's the NTP talked about that being a motivation for wanting to find more person-centered treatment, shorter treatment that was going to be able to support this specifically vulnerable population. And so they are slowly but surely scaling up the 4-month regimen for drug-susceptible TB, and they've offered it so far at the time of writing of the report to about 100 people in the general population, and they're also working on rollout in the prison, the population of incarcerated individuals as well. And they also talked about plans to scale up other shorter regimens, including for TB prevention and for drug-resistant TB. So I think that's a really exciting case study in the report that's worth going and looking at. Next slide, please. And another country that's highlighted, not for a specific regimen per se, but more in terms of being really a leading innovator in terms of rapidly adopting new policy. So this is Ukraine that, has really led the way in terms of quickly adopting new WHO policies, even amidst the war that's currently going on in the country, being able to bring these new innovations in at scale is really an impressive feat that we wanted to highlight, alongside also South Africa that has a different but equally impressive way of scaling up rapid access to new innovation. Next slide, please. And then quickly zooming in on the Global Fund analysis for the countries that were included that are part of the Eurasian region, you can see that the region, in terms of the countries that were included in the report, doing well on rollout of the 6, on diagnostics, on 3HP for TB prevention, and then the gap is really around the 4 regimens. So that's very similar to what I think was observed for the majority of countries that were profiled in the report. This idea that the biggest gap is really around 4 HPMZ and 4 HRZE for drug susceptible TB. So I just wanted to highlight that there and encourage you to go look at it in detail in the report. And then just on to the last slide. So, if there's one message I think to take away from the campaign and from this presentation is really that this work is very much grounded in and supportive of, the goal to realize our shared human rights, most obviously the right to health, enshrined in Article 12 of the International Covenant on Economic, Social, and Cultural Rights, but also the right to science, which is a separate article enshrined or a separate covenant enshrined in Article 15. And that really says that governments have a duty to make available and accessible to all persons without discrimination, especially to the most vulnerable, the best available applications of scientific progress. And that's really what the 146 by 24 campaign is all about. So I think I'll leave it there and leave you with that message that hopefully inspires you in your advocacy to take forward the fight of this campaign in realizing the right to health, the right to science, and access to the best available TB prevention and treatment regimens. Thank you very much.
Дорогая Мадлен, спасибо большое за такую подробную.
Dear Madlen, thank you very much for such thorough and useful presentation and for your attention, which is very important, for your special attention to the successes and gaps and barriers faced by the EECA countries. And now we can switch to the discussion of the questions. Right now, we do not have questions in the chat box, but I hope that colleagues, I think that colleagues, if you have any questions or comments, you can ask them here or put them down, write them down in the chat box. Madlen, thank you very much once more.
And David,
Я смотрю.
feel free to come off mute or off video if you want to join me in answering any questions. David Brannigan from TAG is the co-author of this report.
Так, у нас пока нет вопросов. Я спрошу.
Right now, we do not see any questions in the chat box. Maybe somebody wanted to ask something. Alexandra, Alessia, we can stop the screen demonstration now. Then possibly I will ask my first question. Madlen and possibly David, what would you recommend? Do you have any advice or recommendations to the countries which could not achieve significant results now? What should they start with? Possibly you have answers to this question.
Yeah, that's a great question. I think, well, I guess one of our hopes with this report is that we can sort of give an example of some of the countries that have succeeded and some of the very specific ways that they have done that. So, I would encourage countries to really look to others who are a little bit further along in the process as examples. And I think some of the themes that really emerged from our report are things like working closely the TB program and the HIV program together, especially when it comes to the rollout of TB preventive therapy. So that type of collaboration and data sharing and transparency and partnership was really integral to the success of countries in scaling up TPT. Whereas, say for other regimens, different things emerged to the forefront. Like, for instance, for BPALM, look at the example of really scaling up diagnostic capacity and infrastructure in order to support the rollout of these regimens. Something that was cross-cutting through all the different regimens and all the different countries was the need to involve civil society and affected community members in the messaging around the new regimens in terms of sensitizing both the community to what existed and also healthcare workers to support them to offer these new treatments. So I think, looking to countries that are maybe from a similar context. So for instance, in Eastern Europe, looking to Ukraine and seeing what are some of the ways that they have successfully implemented these policies would hopefully provide some good starting steps for countries that aren't there yet. And David, please feel free to add.
Thanks so much, Madlen. Hi, everyone. So just to add, what countries can be doing to improve access to the shorter, safer regimens. Madlen touched on a lot of the key points. And I just want to also add a little bit of context to the Global Fund funding request data that we used in the report. So this is data that is representing country plans for scaling up the shorter, safer regimens, and not necessarily implementation. Some of the countries have started implementing already, some haven't yet and have plans to. And also there's a question mark around whether these interventions are going to be fully funded by the Global Fund and how the distribution between domestic funding and Global Fund funding will apply. And so I think that while we saw these positive trends of countries planning to roll out these regimens, as Madlen talked through in the findings of the report, the actual implementation and the data on the implementation, there's still a long way to go to get to full implementation. And so there's also like a question related to like now that we have this data, we have these country plans, like actually engaging country governments at the national level and at the regional level to think about what are the next steps here. And one thing is really doing the demand creation work, raising awareness about these regimens, showing that the benefits of them, and then demanding them from country governments. And then it's also a question about data, like where are we going to find out whether the countries are fully implementing them or not? And then, of course, this also, just ties into people being diagnosed. So that's why the diagnostics are really a core part of the campaign. And then so there's really an opportunity, I think, for country accountability to move forward, but then also looking at some of the global actors that have a role to play. WHO, for example, the Global Fund as a major market shaping actor, UNITAID. We haven't seen a lot of progress on the 4 regimens, and for 4-HPMZ especially, we want to start seeing it implemented in high burden settings through operational research, and to really understand how to scale it up more widely. And so there's a role that these other global actors can be playing as well, and to think about in our advocacy as well, asking these actors to step in and take on a greater role.
Дэвид, большое спасибо за ответ. Madlen,
Thank you very much, David, for this answer. And Madlen, thank you so much for your input. And in our chat, there is quite a big question, and it's in English. And maybe I should probably read it in English, as long as I'm in the Russian channel now. Dear Madlen, and can you see that question in English? It's in the chat.
Yes, I can. I'm just reading it now. And if the person who asked the question wants to come off mute and say their question, that's welcome as well. It seems like it's a question about how community members, community agents that work on health promotion can get assistance in, am I getting it right that it's just deciphering test information? So if that's the question, I think and
Hi, Doc. Hi, everyone.
Hi.
Yes, it's me that asked the question. The question that I'm trying to ask is that because I'm from South Africa, so in South Africa, yes, we already had like a few programs launched in terms of them campaigning about like the awareness of what you guys are talking about at this current moment. So what I'm asking is that how do we then like the work that you guys do, how does it involve? Because I have not seen much about the community members, the people that do health promotions. I'm not yet talking about nurses. I'm talking about us promoting the campaign to the people so they know about these treatment plans, they know about these medications that are available, so that people can, once they are educated about it, I think it will be much more simpler for them to acquire these medications if they need them. I don't know if you guys can hear me.
Yes, thank you for clarifying. It's a great question. And I think a really strong component of this campaign is all of the materials that have been developed to support a lot of it geared at, activists in terms of advocating to their governments and to international actors around these shorter regimens. But I think there's also a lot of materials that are relevant in terms of helping support patient education. So we can post, maybe David, you could post the link to the campaign materials in the chat. So I would encourage you to look through there. I think there's a lot there that could be used that's more appropriate, kind of patient-facing, digestible information. Also, GFAN prepared a number of briefs specifically for communities to advocate to the country coordinating mechanisms for including the shorter regimens in their global fund proposals, but those short a lot of the key information. I think one challenge is, you're in South Africa, so I think there is, that's a good context where to focus on patient education. It would be a challenge. Obviously, it's important for patients to know what's accessible to them, but in countries where they wouldn't actually be able to procure those regimens, I think that would be an important, just caveat because they're not available anywhere. And maybe I can take that opportunity just to answer Alice's question in the chat. Yes, BPALM is available in a large number of TB endemic countries, and specifically for ones that are rolling out BPALM with global funding or planning to, as David mentioned in his remarks. That's all detailed in the report as well. And additionally, the World Health Organization does track rollout of BPALM specifically, so there's more data on that in the 2023 WHO Global TB report as well. I hope that answered your question.
Да, Madlen, большое спасибо за
Yes, Madlen, thank you so much for this very detailed answer. There is one more raised hand. Maria. Hello, can you hear me? Yes, we can. So hello again, everyone. My name is Maria Shibaeva, and I work in the coalition of ITPC in EECA countries. Most of the time, I'm involved in intellectual property and access issues, accessibility issues. So like how patents might inhibit the access. It's not a question, I just wanted to add, because the BPALM regimen is really important. So by the way, thank you really much for this presentation, for a lot of updated information that you have provided. Just wanted to say a little bit what we do with regards to access to BPAL in the EECA countries. For example, in Armenia, Belarus, Kazakhstan, Kyrgyzstan, these countries do monitor and collect data with regards to access to BPAL regimens and other TB drugs. In 2023, it was done, and they see what clinical recommendations are, what patients use, what are the national level programs that they might use it under. And in this summer, we are going to publish our report and include these data there. This is the first report of this type, and this experience is really nice. So thank you. And with regards to accessibility and access, we also submitted. So far, there is no patent in Eurasian space for BPAL. There is a request, and at this point of time, the patent is not provided, not given yet. but we filed our objection to the European Patent Agency, not only with regards to BPAL, but to other granulate and amorphic form as well of proteminide amorphic form. And our chemists, they considered it a blocking drug. So now we are getting ready to work with regards to proteminide. We will try to do our best in order for those patents not to be given for these drugs. Thank you.
That's wonderful. Thank you so much for sharing that, and really look forward to reading your report if it's available in English.
Да, он будет готов где-то к
It is
осени.
going to be ready closer to the fall. So each country is going to be to have its country report, and we are going to publish them on ITPC EECA websites. Thank you, Maria, for this advertising. Thank you. It's always welcoming. Dear colleagues, are there any more questions to our speakers, either to Madlen or David? Well, in this case, it means, Madlen, that your presentation was so complete that our participants have no other questions so far. And also, I have included links to the report in Russian and English too. I've sent them to our chat, and participants would be able to look through that and get more information. Dear colleagues, thank you for taking your time. Thank you for your participation in this very important work that we all do. Thank you, dear participants. Thank you, dear speakers. I would like to wish you all good day or evening, wherever you are, and see you next time, dear friends.